Good evening. My name is Saul Morgan. I am going to present a case that regards to atrial ventricle block. A patient was complaining of palpitations in the morning after drinking. Diagnosis: the 58-year-old African-American female with a past medical history of pulmonary embolism, deep vein thrombosis, hypertension. She had a hysterectomy, presented in the clinic with a 5-day history of palpitations in the morning. The history and physical examination, plus with a 12-lead ECG, appeared to indicate that the patient had atrioventricular. Epidemiology of diagnosis. As of 2022, there has been no large population-based studies on the prevalence of atrioventricular block. One study in 2004 suggested that first-degree AV block was more prevalent in African American patients compared with Caucasian patients in all ages groups, apart from the 8th decade of life. This was from Upshaw et al. 2004. However, at this time, there is no well-characterized large studies about the correlation between types of AV block and age, race, and gender. AV block is sometimes seen in athletes and patients with congenital heart disorder. Etiology: AV block represents a delay or disturbance in the transmission of an impulse from the AV node to the ventricles. This can be due to anatomical or functional impairments in the heart conduction system. This disruption in normal electrical activity can be transient or permanent, and then characterized as delayed, intermittent, or absent. In general, there are 3 degrees of AV nodal block: first degree, second degree, and third degree, which is sometimes known as complete heart. This is our P wave. This is our QRS complex. This is our T wave. As you can see, the PR interval is long, but there's always a QRS complex after each P wave. This is typical of type 1 heart. Second degree heart block, Mobitz type 1, Wenckebach. Mobitz type 1 is often a normal variant and is seen in individuals with a large, high vagal tone without evidence of structural heart disease. However, this rhythm can be the result of inferior myocardial ischemia, medication toxicity, AV node blocking agents, hyperkalemia, cardiomyopathy, Lyme disease, etc. Digoxin calcium channel blockers can cause this as well. So let's look at the EKG. P wave, P wave, P wave, P wave, P wave. This is the QRS complex again. And what is interesting about this PR interval is getting longer and longer, and here we have a P wave with no resulting QRS complex. This is a mark of Wenckebach Mobitz type 1. Type 2 heart block, Mobitz type 2, AV block. There is an intermittent non-conductive P wave without warning. Unlike Mobitz type 1, there is no progressing prolongation of the PR interval. Instead, the PR interval remains constant and the P wave occurs at a constant rate with unchanged PR intervals. Because the P wave continues to occur at normal intervals, the RR interval surrounding the drop beat is simply a multiple of the preceding RR intervals. So, again, P, QRS, T wave. So PR interval is the same, then suddenly there's a drop beat. Type 2 heart block, Mobitz type 2, is a much more serious condition than the other heart rhythms we've just. Third-degree heart block. Third-degree heart block, or complete heart block, no electrical impulses from the atria reaches the ventricles. When the ventricles don't receive electrical impulses, the atria, they generate some impulses on their own called ventricle escape beats or junctional beats. Junctional beats are the heart's natural occurring backup, but are usually quite slow. Patient frequently feels poorly in complete heart block, fatigue, and lightheadedness. Subjective information. So again, going over it, 58-year-old African American with a 5-day history of palpitations in the morning after coffee. She denies any family history of note, doesn't smoke, doesn't drink, doesn't take illicit drugs. And the following medications are losartan, Lipitor, and Eliquist. Objective. Vital signs. Blood pressure 197/88. RR is 18, saturation's 98, BMI 31. Cardio, regular, irregular rate, narrow complex, and intermittent non-conductive P wave, no S3, no S4, no murmurs, rubs, or gallops. Respiratory bilateral clear, extremities, 5/5 strength, no deformities noted, and truly there's no other permanent findings found in this patient. Differential diagnosis. The palpitations are secondary to an underlying problem such as anxiety medication or cardiac in origin. It is imperative to find the cause of the palpitations. The 12-lead EKG has given us the diagnosis of morbus type 2. The next question is what has caused this? So morbus type 2 can be caused by a number of different things. Some are anterior MI, septal infection with necrosis, idiopathic fibrosis of the conduction system, autonomic SLE, inflammatory myocarditis, electrolyte imbalance, medication-induced beta blockers, etc., and digitalis. Plan. So the treatment of morbus type 2 involves initiating pacing as soon as the rhythm is identified. Type 2 blocks imply structural damage to the AV conduction system. These patients require transvenous patient until a permanent pacemaker is placed. So with a patient like this, it's important to get pacing done as the patient can go into a rhythm that is not life-sustainable. When this is finished and the patient is stable, then we can look at 12-lead EKGs regularly, 2D echocardiograms, diagnostic blood work, teach the patient to assess pulse, remove many of the predisposing factors as possible, and always refer to the ER when is necessary. Complications. Again, complete heart block, fainting, syncope, dizziness, chest pain, and death, which would be a non-life-sustaining heart rhythm, which the patient can go in. Evaluation of treatment plan. This patient was sent to the ER with a letter from the clinic. This was the first time the patient had been seen at Carlsbad Clinic. It is very unfortunate the patient has not been back. In this situation, an ambulance was considered, but the decision by the provider was that it was appropriate to let the patient go to the ER by her own vehicle. Again, thank you very much. This is the references provided for the images and illustrations. And thank you very much for listening.